Okay, good morning, everybody. Welcome to Mending Kids' six-part series on aerodigestive care. This is the final of six lectures. I'm Leah Jacobson. For those of you that don't know me, I'm a pediatric otolaryngologist at UC San Francisco in California. I work closely with Dr. Fiona Kabagenye who's based in Uganda, and she's a pediatric ENT as well. There are a few other familiar faces on the call, or familiar names, I guess I should say. So thank you all for being here, and I know more people will roll in as we get going today. But today's lecture is really to highlight that I know we've heard from a lot of different doctors over the course of this series and the different roles that different doctors across, ENT, pulmonology, GI, and anesthesia play. But really, we could not do this job and have a comprehensive clinic as we do, supporting complicated kids with, various aerodigestive problems without our support staff. And so today I'm very honored to have joining us our clinical coordinator here at UC San Francisco, who runs our aerodigestive clinic, as well as our main clinical coordinator, who's here supporting her. And then additionally, we have one of our nurses in our ear, nose, and throat clinic who primarily works with kids with complex airways. And so our first presenter is Vanessa Arrazate. She's our aerodigestive clinical coordinator. She's been with UCSF, our institution, for 16 years and has worked with pediatric ENT for 9 years. She worked with case management and the social work department, assisting with discharge planning from the inpatient hospital side for many years, and then has been working with our aerodigestive families since the clinic first started. So I'm very honored to have Vanessa on board to talk about how the clinic was developed from the very start. It actually predated my involvement at UCSF, so she has insight that I do not in terms of what it took to start a clinic like this, and I hope that this will be helpful. And then our second speaker today is Olivia Falandays. She is our clinic nurse in ENT. She has been working in the ENT department since 2022 and has had a background working with in the neonatal intensive care units in San Francisco as well as Chicago, where she's from, since 2017. She works day in and day out with a lot of our children with tracheostomies, so she'll be speaking a little bit about tracheostomy care, since this is such a relevant topic within our aerodigestive patient population. We haven't had a chance to dive too much into tracheostomy care, so save all of your trach-related questions, and Olivia, plus support from me and Fiona, can help to address some of those. So without further ado, I'm going to hand it off to Vanessa to get going on today's lecture. Thanks, Vanessa.
Good morning or good evening, everyone. It's great to be here. Just going to wait for okay. Pediatric aerodigestive care, creating a family-centered experience, collaborating care from a scheduling perspective. Our ADC vision was and continues to be that patients with complex medical conditions could come in and see all 4 specialties during one visit instead of making individual appointments. From a medical standpoint, all providers could collaborate and focus on the child's overall aerodigestive needs, address concerns from parents, and then plan out a concise and individual care treatment plan for these children. These are some of the examples of hardships that some of our families faced. Some of the families live far away from our clinics and require traveling. Preparing for appointments is challenging for families. They must leave their home extremely early, feed the child before leaving, make frequent stops due to medical conditions, gathering and packing all travel needs, such as wheelchair, oxygen, DME, etc. So setting up one appointment where patients are able to see all 4 specialties limited the number of times the families had to face these hardships. Next slide, please. Sorry. Clinical scheduling and room space setup. ENT used their clinic rooms and templates were built for this purpose. All 4 specialties gathered in clinic to see these patients. Once patients were identified, I reach out to the peds, GI, and home practice coordinators to share the list of patients. Then they schedule the patients with their providers in their department. I continuously update the schedule as needed and involve the other clinic coordinators or care team for any add-ons and cancellations. We created visit types for ADC specific patients, new arrow and follow-up arrow. Since SLP is part of ENT, the ENT department, ENT and SLP have the same visit types. I build templates for both ENT and SLP providers. Appointments are 60 minutes. All appointments for all specialties are set up in at the same time. GI decided to use their follow-up and new visit types. Home uses the same visit types as ENT. Next slide, please. So clinic setup. Pre-COVID, we began only seeing 4 patients. Our first clinic was in May 2015, and I can't believe this year, it's 9th year going on to 10 years. It went by so fast. All visits were in person. Patients were scheduled at the time, at the top of the hour, 2 patients at 8 and 2 patients at 10. During clinic, half of our providers would go in to see 1 patient and the other half would go in to see the second patient. Due to high demand, in February 2016, we revisited the number of patients scheduled. We went from 4 patients per clinic to 6, 3 patients at 8 and 3 patients at 10. Next slide, please. Setting up appointment scheduling process. At the time of scheduling, I set the expectations by informing the parent of what specialties they would be consulting with in aerodigestive clinic. I notified them of the duration of the appointment. Some parents complain about the length of the appointment, which is between 1.5 hours to 2 hours. I explained that the ADC clinic dates were preset and occurred on a certain day of the week. In our case, always on a Thursday. Location, I made sure to reiterate the exact appointment location since this could also cause confusion the day of the appointment. I emailed or mailed out appointment letters. Since all appointments were scheduled at the same time, automatic messages were sent for all appointments, causing confusion on the appointment location. Reminder calls, I call families reminding them of the specific time and location. Calls are made 2 weeks, 1 week, and when needed, even 2 days prior to the appointments. Some families required more reminders than others. Our ADC parents have a lot to deal with. Their child's complex challenges, keeping track of multiple appointments, caring for non-ADC siblings on a day-to-day life. These reminders are highly appreciated by our parents. And setting the expectation at the time of the scheduling reduced the number of complaints. Like actually, they weren't complaining anymore. Once it's explained to them, I think their anxiety level went down and they knew what to expect the day of the appointment. So this is our referral process. This is what our referral process looks like. Referrals are made directly to OH&S Peds ENT. The referring provider specifies the patient is being referred to ADC. For external referrals, ensuring all outside records are obtained, faxing medical release forms, requesting that imaging is pushed from other medical institutions, follow up on records and imaging to make sure these are in the patient's record prior to the ADC appointment. I have one of the ENT providers review the referral to make sure the patient requires all 4 specialty services. After all this, the patient is scheduled accordingly. Next slide, please. Setting up insurance and financial. Why can't one authorization request be submitted to the insurance and cover all 4 specialties? Well, each specialty has their own group national identification number. Specific codes, each authorization is specific to the specialty or provider that will be treating the patient. This ensures that all specialties are reimbursed for their services. I secure the authorizations for ENT and speech and language. For Peds, GI, and PULM, their authorization team secures authorizations. Next slide. So COVID transition, virtual ADC 2020 to present, our process. Except for the referral process, we basically had to figure out a whole new clinic dynamic. Video appointments would be scheduled for all services. How would patients be evaluated via Zoom for ADC? Would parents be willing and able to participate in their virtual care? What visit types would be used for these visits? Length and duration, automatic links sent, Zoom IDs for all providers participating, creating confusion. So materials, we had to navigate the Zoom features. We learned about breakout rooms, main session rooms, being able to navigate from one virtual room to another without creating a HIPAA violation. For those of you who don't know what HIPAA is, HIPAA stands for Health Insurance Portability and Accountability Act. So basically, this ensures that patient information is kept private and secured. Who needs to be involved in this process and co-host privileges? Parents access to internet, smart devices, phones, laptop, etc. Offered local resources. And then environmental, creating a culture and process of change for all, setting up training sessions for all providers, mock virtual clinics were set up. We practiced with ENT team a couple of times and then separately with the providers. So this part right here was extremely helpful. The mock clinics, we had several of them, and it made that first virtual clinic run so much smoother because we all knew what we were doing, and that went well. Okay, so next slide, Sheila. Virtual clinic setup. We anticipated HIPAA violations. Patients' families stayed within their breakout rooms, ensured that families were including their child's name on the participant section. We're not including their child's name on the participant section. We admitted one patient. Each patient was verified as it entered by asking their first and last name. Setup options, manually assign, automatically assign, or have the participants assign. So in this case, for the families, I would manually assign them to a breakout room. And we asked the parent to stay in their room until they met with all specialties and were informed when they could exit the appointment. Co-host or host could manually assign. All providers were granted co-host privileges so that they could move themselves between the breakout rooms. Scheduling interpreters as needed in advance was a challenge. Sometimes they would arrive late or not arrive at all. So we just decided to just invite the interpreters just during the appointment, and that seemed to limit the problem with interpreters on arriving to the appointments. So virtual setup and scheduling in 2023. In 2023, we began our hybrid clinic, scheduling 6 appointments in the AM clinic, 2 appointments at 8:30, 9:30, and 10:30, and scheduling 4 appointments in person in PM clinic, 2 at 1 and 2 at 1 and 2, with the option of adding on a 3 o'clock appointment with the approval of the providers. We created an intercommunication tool, our whiteboard. There's an example of this in the next slide. Set up virtual meetings, sent Zoom invites to all providers and parents via email so that there's no confusion with the meeting IDs for each individual in Apex. So everybody uses my meeting ID and password just because the day of clinic, each patient is scheduled with 4 different specialists, and each specialist has their own Zoom ID. So that there's no confusion, everybody uses mine, and I email this to both our providers and our families. And then again, sending reminders at 2 weeks, 1 week, and 2 days prior, calling families to confirm that they will be using the correct Zoom link, even though they may be receiving multiple ones for the other appointments that are scheduled. Next slide. So this is an example of our whiteboard. This is our inner clinic communication tool, which we constantly update throughout clinic. ADC providers complete their whiteboard column by the end of clinic, and they're given 2 weeks to complete their evaluation letters, which are later sent to the families. Next slide. Transferring of whiteboard to patient's electronic medical record. A telephone encounter is created, then all of the notes on the whiteboard columns are transferred over to the patient's medical record. Next slide. Post-ADC scheduling, very important. Appointments are scheduled accordingly based on the team's communication column on the whiteboard. ADC follow-up appointments, modified barium swallow appointments, joint appointments with just ENT and SLP, non-ADC. Coordinated surgical cases are scheduled by the surgery schedulers. Patients are discharged from ADC, but continue to see some of the specialties individually. Peds GI and POEM schedule their own individual appointments. Next slide, please, Regina. So future ideas in April 2025, we will be switching our hybrid schedule. In-person appointments will be scheduled in AM clinic to allow for PFTs and other tests while parents are still on site. Telehealth appointments will be scheduled in the PM clinic. We will be planning for this transition by setting up templates, ensuring that the correct authorizations are in place for needed testing and to be done the same day. We will be scheduling 2 in-person appointments at 8, 9, with the option of adding on 1 patient at 10 a.m. and 2 telehealth appointments at 1, 2, and 3. We will also propose consolidating 1 telehealth ADC Zoom ID. And next slide. And this concludes the presentation on the clinic from start in 2015 to current.
Thank you so much, Vanessa and Rashila, for helping to support Vanessa's presentation. So I know that was a lot of detailed information about how to coordinate one of these clinics, but I just wanted to highlight a few things. And I think for anyone thinking about setting up an aerodigestive clinic, I think Vanessa's presentation highlights like all of the different pieces that we have to think about when coordinating 4 different providers or more than 4 different providers in a single place. There's so many logistical challenges and opportunities that come along with that. And, Vanessa and our clinic manager, Rashila, have been really integral in helping to be nimble and innovative as time goes by. I think, while I'm a little bit familiar with some of your practice settings, I think there are, and, I realize a lot is not necessarily similar to what we do in San Francisco. Some of the similarities that I just wanted to highlight, many of our patients come from far away and face a lot of challenges to get to our hospital. And so relying on a really strong coordinator like Vanessa to help contact these patients. She spends an enormous amount of time really talking to the patients and getting to know them and really understands their challenges in a way that I may not necessarily know from my perspective as a physician trying to focus on addressing a specific challenge or health problem. So I think for anyone thinking about doing this or setting up a system like this, just knowing that looping in non-provider partners to help make this possible is really important, and getting buy-in from the hospital. But the payout is you really get to consolidate care and work very closely with 4 other providers on making a decision through these models. The other thing I wanted to highlight is and Vanessa brought this up in her presentation, is these are longer visits than perhaps normal. So in my normal clinic, I might see up to 20 patients at times in a given day in clinic. In aerodigestive clinic, I'm seeing less than half of that often. And that's because these visits take longer. But that said, you're saving a patient from multiple visits. And so thinking about all the pieces that go into that, hopefully this presentation will generate some opportunity to think about what those pieces may be in respective settings. And to make sure Olivia has enough time to present, we're going to transition over to her. And any questions that come up, please do put in the chat. We'll have some time for collective questions from both presentations. But I've already done an introduction for Olivia, our in-clinic nurse. She's going to talk more about a specific patient population, our tracheostomy population, and how her role in nursing plays into helping to coordinate care for these patients. Take it away, Olivia.
Hello, everyone. Let me just figure this out. Can you see my slides?
Yep,
Yes.
we're good.
Okay,
Yeah.
great. Um, Hello, and thank you, Vanessa, for that awesome presentation, going into all the hard work that you do for our patients. It does not go unappreciated. So I'm going to be presenting on the nursing side of things. Like Dr. Jacobson said, I have experience for the past 2 years in the outpatient clinic for the ENT um, clinic, but I also have experience from the inpatient side working in the neonatal intensive care units. So I wanted to kind of outline what the nursing role is on both of those sides of things. So, as you all know, the patients that we see in aerodigestive clinic can be pretty medically complex, and I know we've learned a lot about the care from other specialties over the past several weeks. So, I'm going to dive into a more detailed view of caring for a patient with a tracheostomy tube. I'm kind of going through a timeline of the nursing perspective of care for before, during, and after the trach happens. I want to recognize that the facility I work in may have some different resources available than some of your practices, and I'm here to share my experiences working with this population and hope that we can come up with some ways to bring some ideas to the areas that might have resource limitations. And I am excited to talk about these options, and I hope that this inspires some thoughts or discussions about how we can adapt processes to your home institutions. Like Leah said, there's going to be some time for questions at the end, so feel free to put them in the chat or wait until the end as you would like. So first I'll discuss the inpatient role of the nurse caring for a patient with a tracheostomy tube. So this begins in the preoperative world when we identify that a patient needs a trach. This could be due to many reasons, such as premature lung disease, neuromuscular conditions, or anatomical airway obstructions. Once the patient is identified as potentially benefiting from a tracheostomy tube, there's typically a family meeting where we have the nursing staff, the family, and the primary and otolaryngology teams. During these meetings, we discuss the goals of the trach and the expectations for care. These patients that will get a tracheostomy tube can be complex and have a lot of work at home, so we want to make sure that the caregivers are comfortable and know what the future will entail. So in this time, we also identified two primary caregivers that are required for the training for going home and any home or environmental needs. We start education early before the trach happens. It is a huge part of the nursing role. And we start by introducing this tracheostomy handbook seen on the bottom right. This has information about introduction to the tracheostomy, what it is, what it does, and then goes into tracheostomy care, including changing how to change the trach and the ties, doing ventilator and suctioning, medication administration, and emergency care. Dr. Jacobson let me know that this handbook is available to you all to edit for your home unit needs. And also in the handbook is 5 videos that go over some of those patient care things that we talked about or that I mentioned. And there's a QR code here for the those videos as well. There's a link also. I can share it in the chat later. Um, but we encourage the education to start early and often. It's never too early to start learning how to care for the parents for the child's trach. So we want to encourage them to feel as comfortable as possible. And we also want to prepare the parent for what the recovery process is going to look like. The patient will likely be pretty swollen, they'll be sedated and medically paralyzed, so they will look a little bit different when they come back from the OR, and we want to make sure that the family is aware of that. All right, so the patient is now prepped and in the operating room. While they're there for their couple-hour procedure, or less, um, the bedside nurse's role is to be to prepare the room for the patient to return with their new hardware. So we make an emergency kit that includes some of this equipment listed here, and these supplies are there to able to help us be able to safely care for the patient with the trach, including supplies for trach changes, stoma cleaning, in emergency scenarios. So making sure that we have the suction set up, oxygen, an ambu bag, and just making sure that we could meet any emergency scenario. The patient after this point should have this emergency kit with them at all times, just in case there's ever an emergency when they're traveling to get a different procedure or once they go home. And after they go home, they receive all of these supplies and then some that help them maintain the patency of the trach and make sure that everything is okay at home. We also will include this form on the right, which is the emergency airway access form. The surgeon will fill this out so that we always know what size artificial airway the patient has and how they can be ventilated in an emergency. And we want to make sure that the family has that with them at all times too in the outpatient world. So once the surgery is over and the patient returns back to their unit, the role of the nurse is to stabilize the patient. They're kept in critical care units for at least a week after the trach. The ENT surgeons do the first trach change around post-op day 5 to 7. So until that time, they're usually sedated and paralyzed, and we don't want them to move much. Because of that, there can be risk for skin breakdown. So the nursing role on top of daily other assessments and nursing roles is to make sure that the skin integrity remains okay. So checking underneath the trach without dislodging or moving the fresh trach and making sure we're doing meticulous safety and skin checks. We also at this time will do include the nurse case manager, which is when we're starting to think about discharge. This is another role that a nurse can play on the inpatient side. And depending on resources, the role is sometimes done by the bedside nurse or a social worker. If there's enough resources, they could have their own nurse case manager for the whole unit. And that nurse will help by doing more care coordination and administrative work, like setting up the patient with the home nursing care, if applicable, and home equipment that they'll need. So this nurse is not doing clinical day-to-day patient care, but is instead on the other side. So these are two pictures of some postoperative trachs. The picture on the left is the patient within their first week of having a trach. You can tell, I don't have my little pointer, I don't think, but on the left there you can see some sutures that are tegaderm taped down to the chest. Those are the stay sutures where if there's any emergency dislodgement of the trach that happens in that first week, they can pull the stay sutures to open up the stoma and replace the trach. So we know that this patient hasn't had their first trach change yet, but you can see that there's a lot of foam dressings to protect. And you can also see that the patient's very swollen, doesn't have much of a neck because they're a little baby. So you can see where you can have opportunity for skin breakdown. And as seen on this picture on the right, you can see a pretty significant breakdown underneath the trach. And for nursing, we are a 24-hour job, so we're constantly checking the patient, and we're typically the first people to notice when there's a change, and we need to be diligent about letting the teams know and bringing these up to the medical team so that we can prevent them from further developing and help the skin recover. So as soon as the patient is stable and the family is able to start participating in cares, we want them to get started. And the education for these patients is ongoing, starts with like I said, before the trach even happens and throughout their inpatient stay and continues with the outpatient nurse, myself. So this form on the right is one of 7 pages that we have the families check off before they go home, and make sure that we have 2 caregivers that are comfortable and confident and have performed different tasks with the trach care. So this could be things like changing the trach and the ties, managing emergency situations, making sure they're comfortable with using the ventilator, and medication administration. We also require our families to be CPR or infant or pediatric CPR trained. And then another thing that we do to help them gain some confidence and make sure that they're ready to go home is do something called rooming in, where the caregivers come and stay in the hospital for 24 to 48 hours and they do all of the cares to make sure that they're comfortable to go home. The nurse's role in that situation is kind of sit back and let them handle it. We can help them if they need it, but we want to make sure that they're going to be comfortable when we're not there. There is a variety of comfortability amongst the parents of patients with new trachs. Some are comfortable right off the bat, and others need a little bit more help to be confident. And it's nursing who's going to instill the family with the confidence to take care of their medically complex child, and it is no small feat. All right, so the time has come. The patient gets to finally go home, and this can be a very exciting and very scary time for families. They don't know who to contact when there's a weird noise coming from the trach, or do they need help with their equipment for the trach? And there isn't the ease of sticking your head out of the room to go to the nurse's station and ask for help. So we try our best to instill them with as much confidence and education to make sure that they're successful when they go home, but it is still quite an adjustment. So this is where I come in. So my role as the outpatient nurse is to be that point person for these families as they make their transition to home and beyond. So there is availability for messaging me on our electronic medical record, and calling the nurse advice line. Um, that that picture is pretty much me on a day-to-day basis. Got my headset on and my laptop, and I'm helping the patients virtually and doing most of my work while they're at home, and I'm on the phone with them. So they're calling in with any questions or concerns, and we talk to these families and triage their concerns. We provide care advice, and we know to loop in the provider or other specialties when appropriate. As we've talked about, these patients can have a lot going on. It's not likely that they just have a trach and everything else is healthy. So we know to loop in and serve as liaisons when we have issues with other care areas. Um, we maintain detailed documentation to track the patient's progress and ensure consistency in care. And we work extra closely with non-English speaking families who need extra support with care coordination. Some examples of calls I've received over the past couple of weeks is advice about ear infections. A patient called because they were having some blood when they were suctioning the trach. Sometimes they'll note granulation tissue around the stoma. Recently, I had a call of a patient who had been home for almost 2 years, and the trach had never accidentally fallen out. This time it happened while the baby was asleep. She pulled it out, and the mom handled the situation. The baby was stable, and then she called and said, "I'd really love to go over some emergency situations." So we just talked through what to do in case of an emergency, and how to keep the baby safe. And I also wanted to touch on another role, I am typically in clinic. While most of my work is virtual for these families, I'm also there in clinic if there's any assistance needed with in-clinic procedures, such as scoping or ear exams and ear cleanings. Another thing that I help with is coordinating equipment from their DME companies. And DME company is DME stands for Durable Medical Equipment, and these are companies that supply the families with home medical equipment. So these relationships are initiated while children are inpatient, and they continue for the duration of the time that the patient's using that equipment. They supply things like home oxygen, portable suction machines like seen here, um, tracheostomy supplies, and others. And we as nurses assist by placing the orders and communicating with the families and the patients to make sure that each patient is getting the supplies that they need. Over the past few years, there have been some shortages in supplies such as tracheostomy tubes themselves. So because of this, we've been encouraging the families more and more to reuse these supplies. And a lot of my education now is teaching them these instructions on the right, which is how to wash and reuse the trach so that they're safely having a clean trach and preventing infection. So that's the end of my prepared material, and I want to see what questions anyone has. And please enjoy this little cartoon of a dinosaur with a trach. All right, you can put your questions in the chat or come off mute.
Thank you so much, Olivia. Yeah, I know this hasn't been the focus of aerodigestive specifically, but I have worked with some of you who are, trying to implement various trach care initiatives, and so I know we're very happy to be a resource for that. And as Olivia mentioned, some of the paperwork and other teaching tools that have been created here are available to you. So feel free to reach out. No need to reinvent the wheel if there are things that can be modified rather than created from scratch, if it's helpful. So yeah, that concludes our lecture series for today. Is Fiona on? Yeah. I don't know if anyone has any specific questions for either of our speakers.
Yes, I have a question. I always have questions. Thank you, Vanessa and Olivia, for speaking. It was absolutely wonderful hearing about how you do the coordination. And I'm extremely humbled by the amount of work that you put in. I don't think I would manage doing the coordination. It seems like a taxing kind of job to do, but you seem to love it, which is really good. In our setting, we generally struggle with such stuff like coordination, even having patients giving you the right telephone numbers. Few of those that come to our public hospitals have email addresses. And then I saw the option for telehealth, and I even wondered how that would roll out in a setting like ours. I'm just wondering, if you were put in a setting like this, what would be the most important step that you would advise? I saw one of our nursing in charges on today. What would be one of the things that you would advise they start with? And that would go for Vanessa. And then for Olivia, thank you for talking about the tracheostomy. I'm just wondering about what the number of the supplies that you ask the DMC to send to the patients, and also curious to know about things like the suction or the unused tubes or the portable oxygen. What happens to them when the patient is finally decannulated? And also to just kind of get to know what you do, what you tell your patients when they need to start the process of decannulation, just for us to know. Thank you.
Sorry, can you repeat my question, Dr. Fiona?
Yes, yes, of course. So if you were put in a setting like ours where you don't have an email address for a patient, you don't have even electronic medical folders, we still use paper-based. Or if you don't, if you don't also have the telephone numbers, how would you suggest, or what would be the fast hanging fruit that you would possibly focus on so that we take it from there?
Ooh,
Hypothetical for you, I know.
tough one, just because, fortunately, during the virtual converting in-person ADT to virtual ADC, a lot of our families, if they didn't have internet access or a tablet, they could go to a library, go to a family home to be able to zoom in to our clinic. We didn't really face those kind of challenges. It was more so our other multidisciplinary clinics like hearing loss clinic. But in your case, what about mailing? How's the mail over there? Could you guys mail appointment letters, or how long does your mail take? What's that like over there?
No mailing.
No mailing. Wow. That's pretty tough. And then no, you said about you couldn't call them.
No, very
No.
few have phone numbers.
Fiona, could you
Um,
maybe just address a little bit like how either referrals work, or like if patients leave the hospital, what is the mechanism for patients to return? Are they getting some sort of like paperwork or something when they leave the hospital to contact clinic, or
They do have a discharge form, and they will be told to come back on a certain day in a certain clinic. So if they don't come, rarely do we get a way to contact them. And some of these people are coming in from the rural setting, so possibly the phone number they gave us is for a neighbor who's rich or who has a phone. So we really lose them to follow up. And I was just kind of trying to pick your brains on perhaps what could be done, what could be a low-hanging fruit, if you have any idea on how we would start that for such patients.
well,
Vanessa, oh, sorry, go ahead. Yeah.
so I think the importance of stressing contacts from the beginning, if they can't be reached at home, is there a relative that lives nearby that they could possibly use their phone number? It's really, and I really feel for you. We don't face these challenges here, and it's it's really sad when you lose when patients are lost to follow up because you can't communicate with them. One time I joked with Rashila, and this was here. Maybe I should have a van and drive to these families' homes and pick them up and bring them to clinic. And that was I mean, that would be ideal, right? If we could do that, if we could pick them up or knock on their door and see what's going on and follow up with them in person. But yeah, I can see how the situation over there would be. It would pose a lot of hardships for you guys as a medical team trying to follow up with these families. And I'm sorry, I can't give you another better answer. Maybe
No,
give
you
me
have. At
days
least
and
you
I can
said
tell you.
stressing. At least you said stressing somebody else who we can reach out to. That's important. Thank you.
Yes.
One thing just to piggyback on that, so that's actually a model I've seen, not specifically in Uganda, and I don't know if Fiona and others, but in one of the first trips I did overseas was to India, and at the time I was working with a group that focused on cleft lip and palate surgery, but their hospital actually and funding this and how this actually works, but they did have outreach volunteers and outreach individuals. I've seen this also in Cambodia, where either a representative from the hospital or, local healthcare workers in a village or in a different district are trained to identify patients or trained to be the point person for that village. So they're the ones with the phone. They're perhaps, there's a house or a center in a region that has internet, and the individuals in that population then know that this is their like healthcare point person. So obviously that's a big logistical effort, but I do wonder, are there equivalents like that, Fiona, in certain parts of the country?
I think one of we do have village health teams, and it's just the tracheostomy care is not part of that package, and maybe that would be an entry point for us. But I have seen home visits, like you mentioned, jokingly, but they've actually been home visits for palliative care, and that could be also another avenue. So, yeah, I think those are important points for us to ponder on. Thank you.
Yeah, and good questions, Fiona. For me, regarding supplies, so the amount depends on the patients that have different insurance companies will allow certain amounts. So they usually get supplies for a month at a time, and then each month going forward, the family needs to order the supplies with the company, and that's to hopefully help prevent like wasting it. Like you said, if they are going to be decannulated, they don't need to get a year's worth of supplies up front. In terms of preparing for decannulation, I think they would get supplies until they are decannulated. Once they get discharged from the hospital after the decannulation, the supply companies are notified and they stop the supplies. Certain supplies can be returned to the companies, but a lot of them don't want to accept them back after they've been in another patient's home. So I've heard of a lot of families using community resources to like give them out. So on like Facebook, they'll have a trach moms Facebook group, and someone will post like, my kid needs this size trach and we're out of suction supplies, and the families will work together to get them the supplies that are unused and safe to be used, but that the companies won't accept back. Did I miss any question?
No, thank you.
Sure.
As an aside, this is something we're working on trying to do as well so that things don't get wasted, is try to collect some of these supplies. We have our trach vent clinic, and so I've started having conversations with families about unused supplies and trying to use our hospital as a repository for those, which can then be shared with patients from all over the world, hopefully. So
That's awesome, Leah.
yeah. Well, we're coming on the hour here, and I just wanted to first thank our speakers for taking time out of their busy schedules to speak to everyone. In the chat, a few people commented where they're from, and we have at least 5 different countries represented today. I'm sure there are more. And so thank you all. I also just want to thank all the participants here, and I'm going to pass it off to Fiona and to Dulcie for some closing remarks on our series. So thank you everybody again for your attention and your time with this series.
Thank you, Leah. Should I go first, Dulcie, or did you want to go first? Okay, perfect. So as we're concluding our aerodigestive care series, we really want to express our heartfelt gratitude to each and every one of you who has made this journey possible. We've had the privilege of learning from experts in their fields. We thank the Pediatric Otolaryngology, the pulmonologists, the GI specialists, speech and language, anesthesia, the nursing team, the coordinator. we're really grateful, and we've covered a wide range of topics which have been crucial to helping us think about how we can provide comprehensive aerodigestive care to our patients in our setting. And we're really thankful for the insightful presentations, the engaging discussions, and the wealth of knowledge that has been shared. I do hope, and together with Dulcie and Leah, we do hope that this series will impact and translate into improved patient outcomes in our different settings. This series would not have been possible without your dedication, your hard work. So I would like to send my heartfelt thank you to the organizers, to Mending Kids, to the moderators. Leah, you've been awesome, and to the support staff. We really appreciate your tireless efforts in bringing this series to life. And to the participants, thank you for your engagement. Thank you for the commitment to delivering exceptional care in your settings. And we look forward to future collaborations and more learning opportunities. Thank you. Over to you, Dulcie.
Nice. Thank you so much. I just want to agree with everything Fiona and Leah have said. We really appreciate you guys. I sent in the chat a link to a symposium, a post-symposium survey that we would love for you to fill out. And if you fill that out, I will send you a certificate of participation from Mending Kids and from Dr. Leah and Dr. Kabaganye, so you can have that for yourself. I will also send out an email with the recording of this lecture like we have been doing, and the link to the post-symposium survey in that email as well. So thank you so much, and please reach out to Mending Kids if you have any questions or want to discuss any further symposium opportunities. Okay, thank you so much, everyone. Have a great evening.